Now that we've discussed the pathophysiology as well as the potential complications of GERD, let's delve into the diagnosis, workup, and management of this condition. The real key when we have a patient with suspected GERD is that we are going to start treating these patients empirically in most cases with the use of a proton pump inhibitor or a PPI. And therefore, this is going to be the first step in management in the majority of our patients with suspected GERD. Additionally, in these patients, if they go on to be refractory to PPIs, we can perform 24-hour pH monitoring in these patients, which is considered to be the best test when it comes to actually evaluating whether this patient indeed has gastroesophageal reflux disease. Beyond this, however, we can go on to obtain an endoscopy in a few key situations. The first being if the patient is refractory to empiric PPI therapy. The second situation is if the patient has long-standing symptoms greater than 5 years. And the reason that we perform an endoscopy in this scenario is because we ultimately want to rule out the possibility of dysplasia as well as cancer, which are our feared complications of this condition. And that's why we write here to rule out Barrett esophagus as well as adenocarcinoma of the esophagus. Beyond this, we should also be sure to get an endoscopy when we have a patient who is exhibiting alarm symptoms. And so therefore, this calls into question what are considered to be alarm symptoms in a patient with gastroesophageal reflux disease. Now, I'm certainly glad that you asked this question, as we've dedicated this entire slide to describing what the alarm symptoms are in a patient with gastroesophageal reflux disease related symptoms. These include a patient having new onset of symptoms at greater than 60 years of age, having dysphagia, odynophagia. Important to point out here that dysphagia refers to difficulty swallowing, whereas odynophagia refers to, oh, I'm having pain while I'm swallowing. Weight loss, persistent or recurrent vomiting, as well as GI bleed. This can include hematemesis, melena, or anemia. And if we see any of these alarm symptoms in our patient with reflux symptoms, then ultimately these should be a tip-off that these are red flags and that we should absolutely get an endoscopy in these patients. Absolutely essential to keep this in mind, especially as we move into our next slide, which is ultimately going to give us the ultimate algorithm for the management of our patients with GERD. Now, the real key here is that when we have a patient with the signs and symptoms of reflux, we should ask two key questions. The first of these questions is this a male patient greater than 50 years old with duration of symptoms greater than 5 years or other cancer risk factors such as smoking? And the second question we should ask is, does this patient exhibit any of the alarm symptoms or red flag symptoms that we discussed on the previous slide? If the answer to both of these questions is no, then we are going to treat these patients empirically with proton pump inhibitor trials. The initial trial is going to be giving these patients a PPI 1 time per day for a period of 8 weeks. If that patient's symptoms persist, then we are going to increase this PPI to 2 times a day or switch to a different proton pump inhibitor, for example, from omeprazole, say, to pantoprazole. If the patient's symptoms improved after either of these trials, then we simply continue the PPI, as we know that this is working and addressing the patient's underlying symptoms. In other words, this patient just has GERD. However, if the patient's symptoms persist even after these 2 trials of proton pump inhibitors, then we should proceed to 24-hour pH monitoring to evaluate, does this patient really have GERD? And after that, we can consider the use of an endoscopy in order to rule out dysplasia, cancer, or another etiology of the patient's symptoms. Moving beyond this, if we were to answer yes to either of these 2 key questions, then in this case, we are going to go directly to an endoscopy with biopsies. If on this endoscopy we see no evidence of esophagitis, then we can perform manometry, which allows us to look at pressures at different points along the esophagus, or we can consider 24-hour pH monitoring, once again, in order to determine, does this patient really have GERD, as this is our best test in order to evaluate that. If, however, on our endoscopy with biopsies, we find that the patient does have esophagitis or inflammation of the esophagus, then we should manage this patient based on the specific etiology of the esophagitis that this patient has. More on this in our separate module on esophageal disorders, in which we talk about, for example, eosinophilic esophagitis or infectious esophagitis etiologies, such as in our patients with candidiasis, CMV, or HSV esophagitis. However, more on that in our esophageal disorders lecture, but for our purposes here, this really sums up all that we need to know in terms of the workup and management of our patients with reflux symptoms. We're essentially asking these two key questions to determine, is there a good chance that this patient has underlying cancer or something really, really serious? If not, we can go ahead and try empiric PPI therapy. If yes to either of these questions, however, then it is our duty to get an endoscopy with biopsies in order to rule out dysplasia as well as cancer. If you like this video, be sure to like, comment, and subscribe, as well as share with your classmates. And we have tons of other great content elsewhere on our channel, as well as at BoardsMD.com. This is BoardsMD, and this is GERD.